I'm Dr. Sarah Coll, orthopaedic surgeon based in Cairns, Far North Queensland. And today I want to talk about surgery after 80. I think we don't have to use 80 as an exact number, but I wanted to talk about surgery in patients who were considered old, and mostly in patients who were considered perhaps by their general practitioner or allied health to be too old, and what their definition of too old is. Probably it aligns with my personal feelings about minority groups or people who are excluded from services and people who perhaps miss out on treatment opportunities. And this is just a cohort that I felt deserved a bit of amplification, not quite the word I'm looking for, but deserved a bit of consideration. So there you go. So why does this topic matter to me? I'm always interested in fit and healthy patients, and this is obviously a cohort of patients over the age of 80. I undertook orthopaedic surgery because one of my priorities in life was to return people to the community and return them to the role that they came from. So an example would be the little old lady who breaks her hip and goes back to her home and bakes cookies for the grandchildren. That to me is a big win. And when I was a junior doctor, I did a metacarpal fracture, one of my very first metacarpal fractures, and I was super proud. It looked really nice on the x-ray, plate was really beautiful, and then my boss came in about 3 months later laughing his head off reading the local newspaper. My metacarpal fracture had done such a beautiful fixation, he was able to rob a bank. So I was returning him to his role in the community. I just didn't quite understand what that might have been. I didn't see that. The other bias that I think we tend to introduce is that the patient can often come in with a neck and femur fracture at that point in their life where they just are not coping at home. And I think that becomes a bias for us because they get stuck in the hospital system. And what I would like to see us as a community do is to start having those conversations with people who are doing that. I don't want to go to a nursing home, I want to stay in my home, and I know we're all dealing with those patients who are like, no, I'm not going to a nursing home, I'm fine, I can manage, when the family really has seen a lot of red flags as to whether or not they should actually be safe at home by themselves. They're getting confused, they keep falling over, and then eventually they break their hip, and with that catastrophic orthopaedic problem, all of a sudden they come to the attention of the public hospital system and the aged care system. So it's just a matter of, I'd like to see us change the conversation around being more positive about making that decision to leave your own home, and whether or not your own home is really as comfortable and as safe and as good as you thought it was. Obviously, the over 80s population is expected to triple by 2050, so you young people will be looking after old people like me. This is a pile of dried mango. This is a very elderly lady. She's had breast cancer, and she had some carpal tunnel symptoms. She had tried steroids. She'd been trying things. She tried splint, she tried steroids, she tried this, she tried that. And she had an endoscopic carpal tunnel release under local anaesthetic, which is something that I'll talk about, which we do very often in 80-year-olds. And we try and give them minimum downtime and then straight back into it, and I'll explain it as I go along. So she was very happy and gave us enormous bags of dried mango. Roberto was written on there because that was the name of the anaesthetist. So age is not a diagnosis, and that's kind of the key point of the talk. There is a huge variation in healthiness at 80, and I'm sure you guys are the same. I see a lot of 80-year-olds from the tablelands. They're really fit and healthy, they've got their own gardens, and they're still quite active. They don't necessarily continuously engage with the healthcare system because they're doing well. I would like to, and I feel like we've talked about this before, frailty is better at predicting outcomes, and their pre-surgical functional status is much more important. There is a huge variation, and the first one that I'm trying to introduce, particularly for junior doctors, is talking about gait speed. So as the speed drops, the survival, there's a reduction in survival after surgery. So if you can do a kilometre in 14 minutes, you're okay, but once you hit 20 minutes, you're not so good. 20-minute kilometre is pretty slow, I reckon. So it is okay to sort of look at their walking speed rather than really, I was crossing the road with a colleague and my grandmother, and she walked across the road and navigated the gutter without looking at it. He said she's got a good survival rate. And she did, she kicked on for at least another 15 years. So it's that need to kind of examine where you're going, that sort of referencing all the time is telling you a lot about the patient. Frailty is common even in community-based people, but in hospitalised people it's jumping up. It's associated, so it's a predictor of a complication risk. So this is not a predictor of outcome, it's a predictor of a complication. So hematoma, infection, falls in hospital, those sort of things. The ones that I want to draw, the indicators that I want to draw your attention to is weight loss. So you can see that their clothes are getting loose, right? They start, particularly if you've seen them previously, you start thinking, my goodness, their clothes are starting to hang off them. Grip strength, so this is a measure, is grip strength, but you just hold their hand, you shake their hand, you touch them. The gait speed, as I talked about before, and then the exhaustion. I don't know about you, but they sit in the chair and then they just look like they don't want to get up again. They just look tired, you feel that they're tired. And then you start taking your history, and I find they're very coy about talking about what they do in a day. I feel like some of them, even when they're very active people still are reluctant to tell me what they do in a day. So I do actually pin them down, and I'll take this up a bit later on in the talk. What do you do each day? How long do you sleep for? What do you do when you get up in the morning? And I think there's these people, my point a little bit is that I'm only in my 50s, so therefore I don't know how to live as an 80-year-old. I don't even know how to become an 80-year-old. But I'm now talking to a person who is 80. They knew in their 50s how to be an 80-year-old. And so how did they do that? What did they do to get to 80? Because they know more about it than me. They're more likely to get to 81 than I am because I'm only 50. So there are surgical risks after 80, and I do address these with patients. So the complication risk increases. Delirium is super important, and I'll talk about how I try and avoid delirium. Higher length of stay, non-home discharge, and I think that's structural as well. And this is again influenced by frailty. Elective mortality, however, is still low. So we're still selecting good patients, but you have to let me, if I say no to someone who's 80, you have to let them be a no. Does that make sense? Like I'll try very hard to make sure they're optimised and I can operate on them, but if I say no, then that means they shouldn't be done. Like they come in, they push, and then if I say no, I need everyone to sort of reinforce the fact that this is not, they really shouldn't be taking this on. There's too much risk. So what do I do after an arthroplasty? The reason why I talk about arthroplasty is the most frequent age, and the age that I tend to see is 83, comes in for a shoulder replacement. And these patients turn up to the hospital and they are excited. So I say, you're about to have a big operation, you're going to be in hospital for a couple of days, and they are so excited because their pain is so bad. Okay, so up here, by the time they present for an arthroplasty, even in private practice, they have left it really late. They do have a lot of glenoid wear, and they do tend to come in with quite significant deformities. I very rarely see them without glenoid wear, without deformity. So they do come in late. They do get a functional improvement, and they do feel that their function improves. The mortality is low in elective cases. Proximal humerus fractures are very different. Proximal humerus fracture is a totally different morphology, much higher dislocation rate, and I don't like doing total shoulder replacements in proximal humerus fractures because it's much more difficult to predict successful outcomes. Patients report high satisfaction rates. I always talk to them about death because I think that people who are 80 have thought about death. They've thought about it and they've talked about it with their significant partner. I think when people die, it's very difficult to understand what their family is going to feel. It's very difficult to anticipate. Sometimes they feel guilt, sometimes they feel sadness. It's very difficult to anticipate. So I say to the patient, if you die, I won't be talking to you. This is not our conversation. I'll be talking to your partner. I'll be talking to your daughter. I'll be talking to your son. can you please have a conversation with them and explain why you're prepared to undertake the risk of death because of your shoulder, right? Now, it doesn't happen very rarely, right? But I just always make sure that I don't have to be worried about talking to their child. Because if they, and the reason why I'm saying it to you is that you can start that conversation before, you know? You're 80. If you die tomorrow, you know, what does it mean? And they'll often have very strong opinions. Some of them will say, no, I have to live until I'm 100. I'm like, well, that's a very different, rehab plan than the ones that say, look, I'm 80, I've had a good life, I've spoken to my partner, you know, we're good. You know, I can't imagine what that feels like, but like I say, I don't know what it's like to be 80. I know what it's like to be 50, but I can't understand what it's like to be 80. After the surgery, I'm really mean on pain relief, really harsh. I'm very happy with paracetamol and have that regularly. Not so excited about an anti-inflammatory, particularly if I'm trying to get an implant to incorporate. I don't know if you're aware, we have an implant that is either cemented, so you cement with like a grout to get the implant to stay, or it's uncemented. So uncemented really means that their bone has to grow into the little perforations on the stem. So in order to get it to grow in, it can't be toggling, can't be wobbling. So I always say if they're getting pain further down their arm, they've got to slow down because the implant can be sort of windscreen wipering inside their humeral stem. So I try and make them slow down. So the anti-inflammatories can slow the process of integration with the implant. So I always try and discourage anti-inflammatories. COX-2 inhibitors might be okay, but I'm always back to Panadol. We use a regional block. So these people wake up with a paralysed numb arm, which is a little daunting. Because they do understand they've had friends with strokes and things like that, so they do find it a bit distressing, but we educate them beforehand, and then it means that they often don't always kick into taking much in the way of opioids at all. Sometimes they'll come off that block and go straight back to Panadol. I don't know how they do it. I think they're very sensitive to any sedation, but I think, according to David, I think they've got a better cognitive manipulation of pain. Is that a fair way of putting it? Cognitive manipulation?
Yeah, manipulation sounds...
You don't like that one?
Yeah, no, yeah.
I feel like they've had pain before.
Yeah.
They recognise it, and they've got coping strategies to sort of look at overriding it, and...
Emotional regulation and cognitive
potentially.
processing.
I mean, maybe you need some of that to get to 80. I don't know. Do you need to have pain management skills? You know? Do you see many chronic pain patients after 80?
Yeah, but less often, I'd say, because I think, and this is purely speculating, but they have less, I suppose, optimism about things they want to get back to. So then less distress about the things less distress about the things they can't do because there's less required of them. And so they may end up having some improvement from that, I'd say.
Oh, you mean because they're not pressuring themselves into doing something?
Yeah, there's less intensity in their recovery and their rehab, and so they may just kind of gravitate more towards less distress and all that.
And have less pain because they're less distressed.
Yeah, and less pressure from all the different factors. And then there's that stigma or the misconception of it. Pain is just a normal part of aging, so then there's less distress about there's something wrong because it's like, well, there's pain because I'm old. And that's just purely speculating because I don't see as many people with chronic pain over 80. But then there's also the funding jurisdictions.
What was that one?
With our work in the residential aged care, lots of chronic pain in that space. So I think sort of seeing rather than just sort of
maybe I'm seeing the ambulant ones in my office. Maybe you're seeing the aged care ones. And so are they medicated?
I think very rarely opioids.
Really?
In
the
the particular facility we go to.
You mean you think that there's an intentional reduction in the use of opioids? Yeah. And does that mean there's just loads of Panadol? Is it just Panadol, Panadol, Panadol?
Very common by comparison.
Any THC or cannabinoid?
Not that I'm aware of.
Yeah, interesting. Yeah, I don't know, and I guess, you know, like I say, I see the ambulant group, and I don't see that cohort. See, I just wonder, it's almost like there's a divergence there. They get pain and then the reduction in activity, and that's where they get the fracture, you know, your proximal humerus fracture, whereas I'm seeing the active ones that wear out their joint and want to get back to that function. And they've got the capacity to wear out their joint, maybe, because they don't have pain elsewhere. You know, I wonder. Yeah, so delirium is a number one problem after surgery, and one of the issues we have is that unrecognised pre-operative dementia and that deterioration. So we'll have a relative that kind of speaks over them and tries to explain things for them. They're a bit deaf, so they keep turning to the relative to check in, or even they're a bit blunted, you know, they're just sort of whatever, you know, the child or the relative wants them to have surgery, but they kind of, yeah, could take it or leave it. So I'm always looking out for some of that, because that you know, they really do have a cognitive dip after their surgery in that situation, and it's just a matter of, because they're so disorientated, it's a matter of getting the family in and making sure that we can reorientate them. I feel like bed rest was a thing, certainly in polio with the iron lungs, and then things like TB and the flu pandemic. And I think bed rest, to me, is not something I ever, you know, encourage. I always try and get them to walk around the ward. Our ward has a little handrail all the way around, you know, they can do laps. And I say to them that the mortality rate is lower if they walk 5 metres in the first 24 hours. I feel like that's a physio study, actually. And so I just try and give them something to kind of hang their hat on, and so I encourage all the shoulders to get up and walk. The risk with knee replacements is they've often had blood loss or a spinal, because they've had that lower limb spinal, they tend to faint, so they have to be supervised. But I'll find that the shoulders will often try and get up, but the older patients feel like they're not allowed to. And they feel like they need to be in bed, they're sick, they need to be in bed. So there's a lot of trying to encourage them, you know, back into their streetwear and you know, out of their dressing gowns and things like that. And you know, the tea and coffee facilities are over there, you know, and try not to sort of deliver it to them. Things I do differently. So predominantly we do endoscopic carpal tunnel releases under local anaesthetic in the 80-year-old population. I feel like they are better able to manage their pain. You know, I put local anaesthetic in hundreds of people, and I can tell, you know, if I put that initial prick in and they flinch, then I've got to go really, really slow. But some of these patients, I can put the whole lot in and they just keep talking. You would never even know I was doing anything. The problem I have is that their blood pressure can be very high, and they'll often stop their blood pressure tablets the day before because they have to stop their medication before their operation. And so they can come in and their blood pressure will be 140 as they arrive into the hospital, but by the time I put them on the table, their blood pressure can be 200. And we ask them if they're feeling anxious or stressed, and they always say no. So what happens is I've got a tourniquet on the forearm, so I use a tourniquet and cut off the circulation to the hand so that I can see without too much blood or oozing, because the hand's a very vascular surface, and that sits at 250, but I need it 70 above their own blood pressure. So I've had patients come in with a blood pressure of 250. So if I put the tourniquet on, it becomes a venous tourniquet, so all I've got is compression on the veins, not on the arteries, so the whole thing just starts to ooze. So I have to do it without a tourniquet in some patients. I always make them, at the end of the operation, I always make them showing full extension and full flexion, and the older patients are quite anxious about that. They don't really, they feel like they're not allowed to. I do a lot of education about it. It's your hand. You know, I'm not the big bad doctor that says you can't do anything. You're allowed to move your hand. So I get them to show me moving their hand. And then I try and encourage early mobilisation. And I've written Teach Family. What I really want to teach the family is to stop making them stop. You know, it's that no, sit down, mum, no, take it easy, don't do that, don't do this, don't do the other thing. If mum's because as soon as mum's left unsupervised, she'll race off and do it, right? So the question is, you know, she's probably going to be okay. I understand it's very stressful, but she's probably going to be okay. I always try and encourage them to return to their usual constipation management. I'm like, you know what constipation is? If you think you might be constipated, you need to deal with it, right? And they always have a little regime. They always know what they like, which medications they like, and they go to the chemist on the way home and they pick up a few extras, right? Do not let them leave it 3 or 4 days. It's often way too late. And I look at their pre-operative mobility, and I try and talk to them about shower chairs and things like that. I understand you probably think we never discuss it, but I do try to make sure that their bathrooms don't have step-in baths, and that's getting much more common nowadays. People are less likely to have them, but we do have that conversation, I promise. Now I've got a one that's trying to get me to sign in. Hydration and protein are my 2 favourite things. Pre-admission dehydration, they get anxious about whether or not they're allowed to drink. We do educate them that they are allowed to drink before surgery, but they don't always believe us. And thirst perception is reduced with age. Okay, so they don't even realise they're thirsty. That doesn't mean that you need to keep pouring water into them, because in fact they don't just have a water requirement, they have a protein requirement and they have a salt requirement. So their protein requirement's going up with illness or surgery, and the protein improves their recovery times if they've got a reasonable protein intake. So it's not just water. Everyone keeps trying to feed them water. If we keep hydrating them, their sodium levels just plummet, because as soon as they're horizontal, they excrete sodium to try and drop their blood pressure, so they get a hyponatremia very quickly. Particularly the frail old ladies that look like me, they get hyponatremia really quickly. And so I just try and give them Vegemite and salt. They sit and eat the salt tablets, the salt packets. So try and encourage them to stop all the food in the hospital is full of sugar, for flavour, to mask the lack of flavour. And so it's about giving them salt, because a lot of the hospital food is low salt, because they're worried about people having high blood pressure. The reason why I put this guy is at the top of his game. He is a senior shoulders and upper limb surgeon, and he is definitely in his 70s. He is on fire. Intellectually, physically, he is working very hard. This generation coming through are going to be very demanding. Not in the aged care home, right? I understand there's a cohort there, but there's a cohort in front of me that don't want to stop, they don't want to retire, they're 75 and they're still kicking along. They tried retiring at 65, they didn't like it, now they're going back to work. I had one guy, 73, who admitted to lifting 50 kilos. He said, I need to be able to lift 50 kilos, can you fix my hand? And he lifts engines in and out of vehicles. He doesn't think that there's any problems with that whatsoever. So, you know, I feel like we see this aged care cohort, we give them a lot of attention, we have a lot of focus on them, and I'm trying to flip the dial a little bit that there can be these super healthy people out there as well. So hospital environment, increased your delirium risk, so it's nice to have your family around. Familiar settings, I like them to go home, and I'll say this again later, they always go home just a bit before I was expecting them to. You know, they always catch me a little bit unawares, and so I really try and have the conversation with the family beforehand. You know, they might come home the day after, because the family's often like, you know, can you keep them in hospital? And then I also, like I say, I try and do the falls planning so that they're safe and independent. So once again, we train in public hospitals, which, you know, public patients have a much higher disease burden, and private patients are elective. You know, they really have not come in from a desperate situation at home, they're elective. They're healthier, and the socioeconomic factors are strong influences on their health outcomes. And I just think it's important, as I said at the beginning, to look at our unconscious bias, our ageism, and those sort of things, to try and make us notice that these people are relatively symptomatic. So like I say before the shoulder operations, they are really sore. They are so happy to be getting a shoulder replacement because they're in so much pain. Much more pain than the knee replacements. Knee replacements, you can't walk because you're sore. Shoulder, you can still walk, you're just in pain. Do you know what I mean? Like you just don't use that arm. So they drop their functionality in that arm, but once it becomes painful, they can't drop the functionality any less. So they tend to wake up early and they have structured meals which anchors the day for them. They have their garden, they have their dog. Many of them are still cooking and shopping independently and they make fantastic dried mango. And they go for walks, they go and do chores. And the food preparation is their independence, right? So all this Meals on Wheels and family coming in and cooking for them, they need to be able to prepare their own food. It's like showering yourself. It's one of those markers of independence that they really value. So I do ask them about that. And their social engagement. Once they're lonely, once they're at home by themselves, I think their mortality rate just skyrockets. They just can't care for themselves because they don't have to get dressed to go out. They don't have anyone coming over and seeing what's really going on in their house. So the loneliness is very dangerous. And social meals improve nutrition. You get more nutrition if you socialise when you eat. So for surgery, I assess their frailty and function, and I do, if I feel like they're frail, they're out. I optimise their hydration beforehand, so I say they are allowed to drink. We will manage, they can even have a quick wee just before they go into the operation, and then we can do an in-out catheter, very low infection rates, in-out catheter if they're really struggling afterwards. Reduce sedation, empower refusal, so I just tell them the problem is the narcotics get prescribed at a fixed time. So 8 o'clock in the morning, they've got to have their endo. So the nurse says 8 o'clock in the morning, they go to the cupboard, they take 2 nurses, check it out of the cupboard, put it in the container. The 2 nurses have to come back, they have to watch the patient swallow. If the patient says no, they then have to return it back to the cupboard and log it as something that wasn't administered, right? So there's a workload involved in a regular narcotic order. So I try and say to the patients, the nurses may feel like they're a bit upset that you don't want it, but you still have to say no if you don't actually have any pain, right? So they're having 0 pain, no pain, and they're prescribed a narcotic and they'll try and take it, yeah? I always encourage early mobilisation. We've got some really terrific physiotherapists at the moment. We really get them up early, and they always discharge a bit earlier than I like, but that's okay. So, key takeaways. Age alone does not predict surgical risk. Frailty, walking speed, handshakes, those sort of things. Grip strength. Many patients over 80 do absolutely fabulously. Lady, that last patient today, she had a total shoulder replacement in 2022. She's come back to say that her shoulder is fabulous. She saw me at 2 months after her operation, after a total shoulder replacement, and I've never seen her until today, 2026. She just didn't feel any need to come and show me her shoulder. She said it was fine. So I find it really hard. I like a regulated, constant follow-up. No, she doesn't want to. She wants to do her own thing. Optimising the physiology improves recovery, and I've picked some very specific things that I like to optimise because otherwise they get completely overwhelmed. They're vitamin D deficient, they're vitamin B12 deficient, there's all those, like they're anemic, all those sort of things as well. And, I didn't want to sort of deliver that message, but we can, monitor all those things. But what I'm trying to say is if I can educate them to get the basics right, then they'll do fine. And respect their self-awareness, and I try very hard to let them make autonomous decisions. And I find that that's very hard in this cohort because, like I said, with the polio and those sort of conditions, those mass illnesses, that the pandemics that we've had, they do feel that they have to comply with a rigid regime. I think that's everything. Okay, tell me what I did wrong.
Nothing, you did everything well. How are you doing when you ChatGPT?
Hey?
Being super critical.
Yeah, I asked ChatGPT to be more critical. Feedback. What do you think? I like the comment about the aged care homes. Go on.
No, I was going to say that we try to assess frailty as well, so listening to that is music to my ears.
Assessing frailty.
Yeah. From that perspective, yeah. I guess rather than feedback was question, was then around if someone, say, has been deemed to be frail, and appreciating that you said it's a no.
Yeah.
Given that if, say, exercise and lifestyle can change frailty.
Yeah, absolutely. Very happy to revisit.
Where's the scope from go away, work with physio? Like, when would you, Sarah, like, feel comfortable revisiting the conversation, like knowing that if we want to put up a
I think once they're frail, you know, they're weak, they've lost weight, they've got, you know, poor balance, slow walking, I reckon you need at least 12 months to turn that around. Do you know what I mean? Like, I really think to really, if they're very dedicated, you can give it 12 months, and I'd be much more confident assessing them at 12 months, rather than like 3 months.
Yes.
You know, go on, what were you saying?
Oh no, that was just, my question was just around, because I guess from our perspective, being able to then say with conviction of, you can reverse this. If the reason is frailty as compared to your, you know, cardiac health, for example, that we can work on frailty, and then we can go back and have a conversation in 12 months' time, for example.
So it's displaying a pattern over time. It's not like a 3 months, I've got to this level and regressing. 12 months is like a good amount of time.
It's a big chunk, isn't it?
It's still a certain regime, and get used to that instead of just doing it for the sake of.
You've got the habits embedded. Yes. So you're right. What we're really asking for is a complete lifestyle change, right? And so they do need time for that. You know, they really do. And you're right, the question is, are they motivated to do that? And that's why I'm saying I do like to ask the active 80 what they're doing. Because the active 80-year-old isn't, you know, doing marathons and kayaking around New Zealand, but they're, so you don't have to get them that good. Do you know what I mean? Like, you just have to get them. They need to be out in the garden, they need to be getting a bit of sunshine, they need to be socialising with their friends. If that involves a walk or a coffee or whatever, I don't care what it is, I couldn't care less. Because I often see in the 70s they're still engaged in community with volunteer work. So in the 60s they start retiring, in the 70s they're sort of engaged with community. But you know, as they hit 80, that's really low, that incidence of that volunteer work. They start sort of dropping out of that. And then I don't know quite what to do with them, you know, to get them back in.
If we had motivated people, or people that aren't motivated, giving them like the goalposts of whatever the screening tool is, or the assessment that you go off your criteria for frail. It's like, this is what, if you can achieve this, we can talk sooner than 12 months.
Absolutely.
And based on where you're at. You know, the physio, the EP, it's physiologically possible for you to turn that into this in this time frame. I love that norm you had of 14 minutes for the 1 kilometre.
1 kilometre.
Because I literally had a patient today, came in, an old DVA, man on DVA, and has never exercised in his whole life. This is the third time I've seen him. He comes in and he had never done purposeful walks ever. And today he's like, did 1 kilometre, took me 17 minutes, I'm doing it in 13 minutes now. And that was today, he's like, oh, great.
Now you got the right numbers for him. He's officially not frail.
Exactly. And he couldn't get up from a chair without his hands.
How long did that take?
This has been 4 weeks. And he's now doing 25. So we had to put the plinth to the bottom, it could go, 41, and then he still did 20. And I was like, all right, well, do that for now, and we'll revisit it. So he has improved his strength drastically.
So that's vitamin D deficiency gives preferential quadriceps wasting. Did you know that one?
No.
Yeah. So they get stuck stuck inside. And then they get stuck in the chair, and they literally can't get out.
That's helpful. I've got a patient that I'm seeing at the moment that is unbelievably frail, and she's in her 30s, and she's got persistent back pain, but she could barely extend her knee against gravity. And she, a lot of sitting with her newborn, contact nursing, and you know, I'm assessing for her fear avoidance initially, and when she says I can't do a squat, her range of motion was fine. So then when she does a squat, I couldn't fathom she couldn't do a sit to stand at all. And it was literally strength, not just fear avoidance. And
not fear avoidance,
And not fear avoidance, And that's what that person I was trying to get that ankle weights for. Because she's trying to do squats with her partner supporting her lift up, and she's very pale, and she is in inside a lot.
Yeah,
So
yeah.
vitamin D could.
And also, you know, they
Beside the
can
window.
Sorry.
Sit beside the window and start.
Yeah, so you've got to make
moving
sure
a chair
the
is a
windows
bit-
aren't tinted.
Yeah.
Right. The office windows in you know, the
Yeah.
capital cities to keep them cooler.
It can
They
be
tint
UV
them.
out.
Yeah, they
Yeah.
UV tinted.
The
Yeah.
UV that you need.
Yeah, exactly. So you've got to actually be outside sometimes.
So what's the rate of atrophy then? Let's just say for like a standard person that doesn't have pre-existing like chronic issues, if they're sessile for how
Yeah.
long
It's
is it?
it's not long.
You have 5% per day, I think.
Whoa.
Yeah.
It's horrific.
With bed rest.
That's quite motivational.
That's motivation.
Me in bed being like I lost 5%.
That's a
So-
lot.
It's a lot.
Even just when you put it in a cast, you'd see that in
Oh,
younger
absolutely.
populations as well.
Or even, I know if they've been wearing their sling after their rotator cuff repair, because they've got no deltoid. Zero. It's gone. It's like, looks like mine.
Yeah. And I mean, spinal cord injuries where they suddenly the wastage happens so quickly.
But even anyone with the fractured femurs that used to go in traction, you just watch these big guys, these tradies come in and they're just wither away. And of course, you know, their physiology changes. You know, they're drinking all these high protein. You know, they're catabolic. You know, it's really difficult. Yeah, so it's significant. Stop. You can't stop. Which I think, you know, back to the 80s, I think they just never stopped. You know, they tick over, but they never stop. You know, they just get out and grow the tomatoes. May's the time to start planting the tomatoes, apparently. They come up in October, they're all out there doing it, you know? So,
We probably do see, like in the aged care again,
Yes.
I feel like once they hit aged care, it's the opposite. They all don't want to do any exercise or even move because they
No.
say, I've spent my last 80 years
yeah,
being a
yeah.
cane farmer,
Yeah.
and then they have no drive.
Yeah, that's
Maybe they have all
interesting.
the drive until they get to the aged care, and then they're just like, some of them are just like, I just want to lie in bed and do nothing.
Yeah, I mean, I guess, you know, maybe they're sort of processing the transition. You know, they've got that cognitive load of what does this transition really mean, and that's all they can manage, you know, at that time. But as you know, they do sort of eventually start getting curious about what's going on outside their room. You know, some of them.
Some of them, yeah.
You know, they start getting that. But you're right. Look, I think, you know, some people do choose that time to die. You know, they say, you know, I worked my life and now, you know, I'm okay if I lose 5% of my muscle mass.
Yeah.
Or muscle strength, sorry. You know, so, and I can respect that decision, but I always try and have that conversation. You know what I mean? Like, if this is what you're here for, sure, I can buy into that, but, you know, it's not going to be pretty, but that's okay. It's your call, you know?
Yeah.
Go on.
Oh, it's just, again, there's people at the aged care facility that some of them just, you're like, yeah, when are you going to start deconditioning? Because you haven't been doing anything. But there's just the odd few that, like,
Stay
when you do test them, and they're like, oh, like, stand up for me, and they can just jump straight up. But then there's others, you know, like,
No, I reckon
But
it's
within weeks,
definitely, I
but-
reckon they're still sneakily. I reckon they're up to stuff. Unless they had a good, you know, really bulky beforehand, I reckon.
Yeah.
But did they lie?
yeah.
Sneak out.
Yeah, they sneak out to their
business
squat
mates.
exercise and
Yeah.
pull up the weights, and I don't know what they're up to.
I'm
It's
thinking
2 o'clock in the
some of
morning.
the ones I'm thinking of eat very well, so I don't know whether that's
True.
sustaining a bit
Sustaining
more.
their
Get some
protein.
sun.
Yeah.
But I
And
think
move's good.
But even to have an appetite, you have to move.
Mm.
You know, I really think their appetite, you know, like they say, they don't recognise thirst. You know, they don't sort of, their appetite is reduced anyway. You know, so I reckon you need a tracker.
Yeah.
Wait till they've all got trackers. Wait till they've all got Apple Watches and you're like, I see how many steps you're doing. You know, like I just wonder, we don't really know. We're guessing, it's like diets, you know, like we're always guessing as to what people are actually eating because we don't know. It'll be interesting to see once we start tracking things and knowing what people, I don't know, I'd be interested to see what they do. But I feel like the 80-year-olds, you know, sometimes they come in and they'll tell me that they've had significant surgical procedures, you know, they've had cancers and resections and, you know, cardiac issues, and no, they got back up and got going again. You know, I'd love to see what we're doing right for them.
Yeah, and the people that, so we work with people right before they get an aged care package.
What does that mean? Explain what you mean by that.
So the
I
aged
have
care
no
package
idea.
is like a lump of funding from my aged care,
Yes.
from the government.
What age? Is there an age thing? When does that kick in?
I think it's over 65.
That's very
Yeah.
young.
Yeah, you get an assessment based on your need, I suppose.
Come
And
on.
then,
I think we're due for cheap bus fares in about 4 years.
Yeah, you're before me, so.
That's all that matters. Okay, so you're in up for an age package. So, okay, so I'm 65, I'm ready for my age package.
And then
Age
they-
package. How much
well-
is it? How much money do they get?
oh, I don't know anymore.
I'm not
It used
sure.
to be 12 grand, I think,
Okay.
but it's changed.
Can I apply?
Each, yeah.
Like some physio sticks.
Oh, no, because it's before they actually get into the levels of packages. Yeah, it was called the short-term restorative care program.
Okay.
I don't actually know what it's called
Does it still
anymore.
exist?
It still exists, but it's just changed over in October to this new one that seems to not even be happening.
So the intention was to kind of veer them off the aged care of $12,000.
Yeah,
Veer them off and
it's
kind of,
to give them early intervention,
yeah, sure.
early or appropriate intervention to prevent the decline into the home
Yeah, sure.
or to the need of a
Yeah.
Aged care
So what's
package?
the first package?
12 grand, 8
To
weeks
what? For 8
to
weeks.
get allied health, lift chair,
And you've got to spend it
OT.
in 12 weeks.
Yeah, so it's a lot to do.
Okay.
It's a lot to do.
Something invoice.
Oh my goodness.
I've
And
never
this-
seen a more motivated group of people.
I hope that you get into this.
Yeah, like I don't want to go into a home.
Oh, you mean the patients are motivated? I thought
The
you
patients,
I thought you were
yeah.
saying the care providers were motivated to
Oh.
get everything done in 8 weeks.
Oh, well, they're also motivated.
I was getting concerned they're going to be a bit of a burden, and do we really need to keep them fit? But if they're going to be spending government money, then there's actually a good return for.
Oh, I think it's the best money the government spends in
Why? Why?
Because it's this opportunity to
Apart
not
from fluoride.
to not progress into a home. Because you know how they all get to the home and they go, oh, it didn't work, I'm here. You know, the
Why?
things that
What do you mean?
like the
That
things
seems
they
fairly
tried to
obvious.
stay away didn't work. So that's where they're like, well, what's the point of exercise? What's the point of all
Oh,
things
no.
else? Because
Okay.
I'm still here now.
I would be concerned. I wouldn't push that point too much because there is a supply issue with houses, and the government will actually do something that's
Yeah.
actually part of the problem.
Yeah.
Because they need more
More
supplies.
houses
So
aren't
make
done.
them-
Yeah.
Go on. Okay, so you go in, and
we-
within 8 weeks you've got to turn them around.
Yeah, and within, like that guy, within 2 weeks, they're already getting stronger. And a lot of them don't even understand that you can get stronger as an old
I
person.
know. I have to
A lot
reinforce
of them
that
are
as
like,
well.
oh no, I'm weak because I'm old. It's like, no, you're weak because you stopped working and you stopped this and this and
Yes,
this
yes.
and this and this.
Yeah.
And as soon as they start doing things, they get stronger and they get way more functional.
Someone told me that yesterday.
Those old people.
It's very low hanging fruit in terms of outcomes, I find.
Yeah, I agree. There's good studies that show that they build muscle very quickly because they're sort of so far behind.
Yeah.
Okay, so you do an assessment and you do an 8 week and so then their first aged care package is that in the home.
No, so at their own home. They're still at home.
You're doing them at home
Yep.
to try and prevent them from going into a home.
A
into
care facility.
Into
kind
a
of
care
thing.
facility.
Yeah.
Right. Okay.
And that's what it's pitched to them as. It's a way to stay as functional as
But
possible.
they're very motivated to stay at home, aren't they?
Oh, yeah, I don't think there's anything people are more motivated for. like,
So why do you think?
all-
Okay, so why are they motivated to stay at home?
Independence.
So what?
Their identity.
Why?
Their stoicism. Their
Because we've got this, like I say, because
Yeah.
it worries me that we're leaving it too late.
Yeah.
Because
it's a
they have to
problem.
be at home,
Yeah.
right? And no one's having that conversation about, well, no, you're not fit enough to be at home, and you've hit the frailty marker. Sorry, you're off you go, right? So we don't do that in Australia, I don't think.
like forced.
Not so much force, but we have this culture that you know your home is your castle, and anyone ever wants is to buy a home, and having home ownership is the be all and end all. But then I wonder if that sort of collective living, that communal living that they've got to go into, I don't think I like it, but I feel like it's not kind to make them wait till they're 80. Do you know what I mean? Like,
The problem is they don't have the insight to know they're not capable. So they're at home
you must be telling
thinking,
them.
sorry?
You must be
Well, the
telling them.
OTs, that's their
When
job.
you launch it, you come in with your $12,000 package, they must be thinking, oh, here it comes.
Well, I don't actually know whether or not when they do the assessment to put them onto that program, whether there is a flag to say, well, they need to be put into a care facility immediately. Because the people that we see in that package are relatively functional and there's a lot of opportunity. So I actually don't know what happens.
Or is there another cohort that you never see?
Potentially,
Go in?
potentially, because I can't think of anybody that I've ever seen where I have thought there's no hope for you. You should be at home.
Okay.
You have?
You have? You've
Yeah.
assessed them as too frail?
Well, it's having a conversation typically with the other caregiver, or the caregiver for how are you going? Because if this is getting beyond the point where you are doing all of the work, you're burning the candle both ends, like carer fatigue.
Yes.
Something happens to you, well, they are going into a home because they're
Yes.
unable to look after themselves. So
Yes.
that's, I guess, the point where you're having a conversation. I've had that a few times where it's, something needs to change here because if something would happen to you, they're going into a home.
Well, see, that's kind of my point about
Yeah.
the death one. Because
Yeah.
they must have already had this conversation. So you couldn't possibly be introducing a new idea.
No.
Do you know what I mean? Like, once you're married, you kind of, and you're frail and you're retired. Surely they must have had the conversation, say, look, if you go first, I'm going to do this.
Normally it's a behavioural component from the frail person, as David said. David says stoic. I'm adamant. I'm not going.
Yes.
If we have that conversation, they'll get angry, and so we're sort of tiptoeing around it. There's normally a behavioural component as to why we're not gently prodding in that direction.
I just feel like that's the elephant in the room.
Yes, 100%.
Right? We don't actually have a program for that, or there's no strengthening program for that behavioural component. I understand you're trying to address it, but you're still tiptoeing around it.
Yeah, it's complex because often the kids are even telling them they should be going to the home. Like this
the kids are sometimes seeing the flags.
So I see people who have a package, and a lot of them, it's like, oh, you could be close to going to a home, and the kids are saying you should go to a home. Everyone is saying it. They're still like, no, I don't want to. And then it would come down to behaviour change and motivational interviewing, but then at the end of the day, if that's what they really want, then we can give them all the information, and then if they choose to do that, then...
I'm not saying I think they should be forced into an
but just from our perspective...
I just think we need to destigmatise it, I think you're right.
Yeah,
I think
There's a lot
they're
of fear
frightened,
around
it's
it.
unknown.
A lot of fear around
It's very
homes.
Yeah.
It's
I
like
think
there's
the
like
care
quality.
might not be what they want, and they may lose their independence and their autonomy, and I get that. But then you get the patients that go in and it's fabulous, and they have, sometimes they really blossom.
Oh, I can think of two
Bit
people
of extroverts.
that have thrived when one went into respite while their daughter went overseas. This was torn Achilles, ruptured Achilles, and then declined when she went home again because the social,
Was so good.
the social engagement in the facility was huge, and I just forgot the other person I was thinking of. But yeah, I've heard people that
They step up and start running the bingo.
thrive. Oh, this lady was blind, so very, very blind, and so she was so independent, fiercely independent, and couldn't see, anything, and she couldn't hang out with people because she couldn't even walk around.
Couldn't get to.
She couldn't get to people. Whereas, and she didn't go to a home, but she was someone who was morally opposed to it, and she was sort of like, oh, you are craving human
Yes.
interaction and social engagement, and I felt and I spoke to her about that stuff.
But I think also she's going to really struggle because she's got that mental map of the home, and she's going to have to learn a whole new mental map, and that would be frightening. But it, it would have to be lots of practice runs of, counting out steps and, finding handrails and things like that. But if she had a handrail that guided her, do you know what I mean? To where she needed to go, then she could move more.
Yeah.
Go on.
Yeah, she'd move a lot more. She exercised heaps. She was super motivated. But the problem was she was going so fast walking in the living room. It was like, oh, this is actually a risk for your vision, isn't it? I'm not super comfortable how fast you're walking. And she just took it upon herself and just started looking fast. I was like, that's not the goal. Let's work on power in a different way. Because she could see, but just like really badly, like within 30 centimetres kind of thing.
Yeah.
So the risk,
That's interesting, isn't it? And also, she doesn't know when she's going to suddenly come across a flight of stairs and, just terrifying. So I can understand why she'd be reluctant, but I just, maybe it's the stigma associated, with the level of care. And I do get some positive reports that people are sort of so relieved, And then also, we've had a couple of patients come from the nursing home. One was a nurse, and she was an inpatient in the nursing home. But the logistics of getting her from there to here is incredibly challenging. Trying to organise transport, and who's going to come with her, and was she able to bring someone, and and trying to get her even down. She had a larger wheelchair, and she did it, but she was very educated. She'd been a nurse, she knew what she wanted to get to, and she knew what she wanted to be able to, what she wanted done. But she was a carpal tunnel. It's not unknown in the 80-year-olds, it's just untreated. And I don't really want to do, 50,000 carpal tunnel releases on 80-year-olds. I'm not saying that, I'm just saying that if a carpal tunnel is something that can give them a better night's sleep, then I think we owe to ourselves to identify it, but then they tend to underreport because they don't want to do it because they're frightened that they're going to have a problem with an operation. And so it's, just trying to educate them that it doesn't always, they're used to sort of giving up all their autonomy whenever they have surgery. And they know they can't really sacrifice that at their age, because if they give up their autonomy, they know they're going to get deconditioned and they're going to really struggle, and someone will put them in a nursing home if they give up their autonomy. So they kind of, it's about, I do a lot of affirmations of, you will be able to move your hand, you're allowed to, take the bandages off, you're allowed to take the dressings off, you're allowed to use your hand if it feels comfortable. And they come in and they've got a full range of motion, particularly the older ones. So over 70s always have a full range of motion at post-op review at 1 week, and the 30-year-olds very variable. Usually don't have full range of motion.
Oh.
Yeah, why's that?
Yeah.
I don't know. It's cool, hey?
Yeah.
The 30-year-olds invariably struggle, and they have a bit more pain. I don't know whether or not it's the different activity levels.
You just can't slow down with 30-year-olds.
The 30-year-old can't slow down because they've got responsibilities.
Yeah.
Maybe the 70-year-old can, but I've had a 75-year-old who was lifting 25-kilo jerry cans before the first week was up.
Very impressive.
Hey?
Very impressive.
Yes, weird. Yeah, I'm surprised. I don't know why. I mean, I can understand maybe he's just doing like a little hook grip rather than like a wrist extension grip.
Yeah.
That's what you recorded. Whether or not it's true, I don't know. Yeah. So they I mean, that's kind of my point. Is their range of motion is always much better.
And then what it allows them to do if they're live, if they start low mood and distressed about going into a kind of home because they can't do the things they love, it's like, well, if they get that surgery, could they keep knitting? Or keep
yes, that sort of stuff.
or
Yes.
what?
Yes, well see that's the thing they do is they say, I can't knit anymore because I've got a trigger finger. It's like, wait a minute, it's a trigger finger. That, like, that's not a reason to stop knitting.
Yeah, and then stop living.
Yeah. That's why they have to come and look, sure, if they've got arthritis and things like that, but for a trigger finger you don't stop, and it's not worth it. little things, and they heal beautifully. You know, they look after their wounds. As long as they look after their wounds, they heal just fine.
How simple is the procedure for a trigger finger?
Oh, transverse incision.
Is that just like super quick recovery?
10 minutes. They can take 4 weeks to. They say they've got puffiness, and they say they get PIP joint pain because they can finally extend their PIP joint to its full range. Does that make sense? Because they've been sitting in slight flexion. Yeah, they've been sitting in slight flexion for as long as they can't really remember.
Yeah.
And so they come in and they say, why do I have PIP joint pain, and then why do I have swelling beyond the scar? They don't have swelling before the scar. They have swelling after, and they always notice. I don't know why they're like, what's this? I'm like, we had an operation.
You're a wonderful self-healer.
So sometimes they're a little slow in pulling all the way down, but sometimes they've got splits in their tendon, right? So the tendon's not got transected, but it is, it's got these longitudinal splits in it, and I think that might make it a bit harder to pull it down.
Yeah, right.
Does that make sense?
Like, I feel like old people do just, maybe they just think trigger fingers are insignificant, not worth, like,
So
same as the carpal tunnel. Like,
so
you see people in aged care, it's I got a trigger finger, had it for 20 years. It's like maybe they don't bring it up, you know? Like,
yeah, I did have one lady who'd had it, you know, every morning at 3 o'clock every morning for 12 months. She had agonising pain straightening out her finger, and I was like, oh, you've got a trigger finger, would you like an operation? She's like, are you kidding me? She's like, every morning for a year, this thing's been hurting me. It wakes them up.
If you did it in an elderly person though as well, would their finger then go straight, or would it just be like contracted?
Sometimes they've got a Dupuytren's contracture, and that's different, right? So you just got to be careful that you've got the diagnosis. But if they can fully straighten it in between, then you're fine. I know when I mean fully straighten, you know, even if you've kind of got that, that's all right. Yeah. But if they're not having intermittent episodes of triggering, then you've got to be a bit more careful. But yeah, so that's why I say she was like, oh, then I have to go back to sleep.
I think, like, sort of what you both said, but a conversation that I've had with an elderly patient is like she said to me that she will stop seeking out healthcare because she's sick of going and people telling her she's 94. That's because you're getting old. So she's like, why would I go and tell my doctor, whoever, why would I complain? Because they're just going to tell me, don't worry about it, you're getting old. So I think that validation of my symptoms are real. I can still live a good life if something were to be done about this.
Yes.
It can be really harmful.
And I
really like the idea of here's the factors, the criteria, if you meet them, we'll do it.
Yes.
Yeah.
Yes. Yeah. And you know, I got a call, 93-year-old, had a full supraspinatus subscap, lots and lots of pain from tears, rotator cuff tears. Now, the problem with that is that the tears are usually much older, and actually you've got an osteoarthritic shoulder that's had a knock. And so she's like, oh, you wouldn't want to do anything, would you? Like, that's how the question starts, right? Oh, you wouldn't want to see this lady because you wouldn't want to do anything because she's 93. I'm like, hold on. You know, like, she could be better than a 63-year-old. You just, like you said, with your 30-year-old, you know, people can be deconditioned very young, and we still would never say, oh, you're 30, you know, you wouldn't want an operation, would you, because you're deconditioned and frail. Like, we just wouldn't do that.
Maybe it'll get better now that everyone's got Garmin to tell them their, what's it called, training age or biological.
Does it tell you your biological age?
So it'll tell you your biological age.
And then your fitness age.
That's terrifying.
I can't I did.
So where does this come from though? Like, even in the medical professional of, it's just you're getting older.
Oh, where does that come from?
Yeah.
Well, because when I was an intern, 60 was pretty old. Right, so 30 years ago, 60 was pretty old, and in fact, there was a lot of provisions, like you weren't allowed to go to ICU after the age of 60 because you were too old.
Wow.
You know, things like that. There was a lot of age restrictions on things, and that's why the retirement age is 65, is because you were retired and then you were dead in a year. You know, like, and so that's what I was talking about, this glut of 80-year-old people coming through in 2050. You know, we don't really have the social mechanisms to manage that because we keep telling them they're going to die. You know, we keep so after the age of 75, you'll no longer receive a letter from the government to recommend you get your breast screening. You can have it, it's still free, but you don't get a letter.
Okay.
Right, so they stop screening for cancer
Yeah.
at 75. So that means you get late presentations at 85 with breast cancers, you know, they're coming really late.
Yeah.
So then they have to have more extensive surgery. But you didn't do the screening, so
So
Yeah.
are they doing this to cut costs, or are they finding it's too harmful doing the screening?
Isn't there
There's a balance in it.
Isn't there a bowel
It was
cancer
a
one as
cost
well?
thing,
That's
but
supposed to
Yeah,
be
what's the
like
cost?
without you?
What's
Yeah,
the
it
age
is.
so
At
if they do have
50 it's
cancer,
allowed out.
what's the length?
Yeah,
How long
and
do
they're
you
trying
want
to
to
push
use that
it
cancer?
to be younger. That it
You
gets
would like, you live
Oh yeah,
you
because
live
of time
for 3
issue
years,
in our
yeah.
generation.
Right, so
Yeah.
you're gonna,
Actually,
what's the ethics of
What, putting you through that?
what age do
and
you
then
want
giving you the stress
to
and
put that
anxiety of
from to?
Yeah.
Who do we want to capture?
If they can do
And
anything with
why?
it,
Do we want to capture the
normally
40-year-old
the next
because
10, 15
they're
years.
productive?
Don't know.
But we don't mind if we
It's
miss the
brutal, but
It'd
60-year-old
be
because
inevitably based
they're
on
not
that.
productive.
Yeah.
You know, like,
Of-
it's
It doesn't
it's
how many
structural as well
scans, how many
as
scans
social.
that are
Yeah.
painful. It's the same
That's
as
so
taking
interesting.
away what
Yeah.
MRIs over the age of 50 on the knee. Like they just say, well,
They are taking it away.
that's all they have, haven't they? So-
I can do it, but
yeah,
I
also
wouldn't
like
know.
GP, so GP
Yeah.
referred me.
You can't do an
Because
MRI
you go and
after
you get
50
an MRI,
of the
it's
knee.
like, you got degenerative meniscus,
No,
like
no.
they just cut costs. Like, so it'd be the same thing, I'd imagine.
Yeah, because an arthroscopy after 50 is contraindicated because you don't need it, right? Because you should just have a knee replacement, right? So if you have a meniscal tear at 50, you just wait until you're 60 and have a knee replacement, right? When you could have a 30-minute procedure in a day surgery, or you can have a major procedure
10 years time.
in 10 years' time.
And hope your quality of life is still good by that stage.
Well, it's very difficult to work on a meniscal tear. They don't like it and they struggle to keep working. And so they're still not at retirement age, so they, because retirement age is 67, so they go back at 60 with a knee replacement, but you can't get, it's hard for them to get those walking distances after a knee replacement. You know, the big 10,000 steps and stuff. We can, thank you, you can hear me.